from the Leicester University Hospital and Dr. Vichitra from the Congen University Hospital, Thailand. Okay, that time to start with the first paper. Today we have the 5 paper today, and let's start by me. Okay.
The first paper regarding the effect of modified Blalock-Taussig shunt to pulmonary valve sparing procedure in patients with Tetralogy of Fall. Dr. Silipop, please.
Thank you. Not work. Play เลยฮะอันนี้ก็ได้เหรอนานไปหน่อยได้ไหมโอเคได้ครับโอเค sorry okay first of all I would like to thank you the organizing committee to accept my paper to present today. Today I would like to talk about the effect of modified Blalock-Taussig shunt to pulmonary valve sparing procedure in patients with Tetralogy of Fall. I am not this culture. This is my hospital. The Leicester University Hospital located at the lower northern of the Thailand, and the name of my hospital came from the great king of my country. So, the modified Blalock-Taussig shunt is an essential procedure for the symptomatic Tetralogy of Fall and can promote growth of the pulmonary artery and also encourage growth of the pulmonary valve annulus. This data was supported by paper from Japanese group. His study show about the direction of blood flow change when you did the modified Blalock-Taussig shunt. Before modified Blalock-Taussig shunt, in patient Tetralogy of Fall, the blood flow toward directly to the RV free valve, and after that toward to the pulmonary valve annulus. When you did the modified Blalock-Taussig shunt, the blood flow changed directly toward to the pulmonary valve annulus. And this is the reason why the modified Blalock-Taussig shunt can promote growth of the pulmonary valve annulus. And this result is corresponding to my previous paper that I present on the ASCVTS on last year. That show the pulmonary valve annulus grows significantly after you did the modified Blalock-Taussig shunt. However, the impact of modified Blalock-Taussig shunt to increase rate of pulmonary valve preservation remain controversy. The primary objective was compare the success rate of pulmonary valve preservation between the stent repair and primary repair in patients with Tetralogy of Fall. And the secondary objective to determine the modified Blalock-Taussig shunt can be delay the pulmonary insufficiency after the complete surgical repair. We decided to study about the retrospective case control study, include all patients with Tetralogy of Fall who underwent repair from the 2 cardiac heart centers at the lower northern of the Thailand. We include during the January 2005 until December 2017. We select this period of time because after the 2017, we changed a policy to the early primary repair. We can enroll 112 patients and to divide into 2 groups. The first group is the primary repair as the control. We have the 83 patients, and the study group we have the 29 patients. The indication of the stent repair is a hypoxic secondary, profound desaturation, or the small branch of pulmonary artery. We exclude the complex tetralogy of Fall, such as the death with the complete avistotal defect, or the absent pulmonary valve syndrome, or absent unilateral polyartery, or the other complex malformation. This table shows about the preoperative demographic data. There were no significant difference between both groups in gender, age, body weight, height, preterm, low birth weight, and the underlying condition. But we found the prevalence of the patent datarosis more common in the primary repair group. When we are looking at the echocardiographic data, we found at the first time of the diagnosis, we found the right side heart structure, such as the pulmonary valve annulus, main pulmonary, right, left pulmonary, and maculature in the primary repair group were bigger than the state repair group significantly at the initial time to diagnosis. However, at the last time before the total repair, we found the pulmonary valve annulus, pulmonary valve score, right pulmonary score, and maculature were larger than the primary repair group significantly. Therefore, the success rate of the pulmonary valve sparing procedure in the state repair group more than the primary repair group, even though the diagnostic pulmonary valve morphology in the primary repair group is more common. However, the cardiopulmonary bypass and the aortic cross-clamp time in state repair group were prolonged than the primary repair group. Additionally, we found the in-state repair group need to the reconstruction of the right pulmonary more than the primary repair group. The overall immediate perioperative morbidity and mortality, there were no significant difference between both groups. When we looking at the severity of the pulmonary insufficiency, we found the moderate to severe pulmonary insufficiency in the primary repair group more than the state repair group, significantly at the time to discharge and the time to last follow-up. However, we try to evaluate the Kaplan-Meier for the evaluate the effect of modified Blalock-Taussig shunt can be delay the pulmonary insufficiency can be delayed about estimate 3 years after the operation. And after 3 years, the severity of the pulmonary insufficiency was equal. In this era, the aim of the Tetralogy of Fall repair try to preserve the pulmonary valve annulus for the prevent late RV failure. Our results show the modified Blalock-Taussig shunt can increase rate of pulmonary valve sparing, even though the initial size of the pulmonary valve annulus in modified Blalock-Taussig shunt group was smaller than the primary repair group. No significant difference was found in the rate of the pulmonary valve sparing in different surgeons. However, the major problem of the modified Blalock-Taussig shunt was introduced the right pulmonary or pulmonary stenosis more than the primary repair group. In conclusion, the modified Blalock-Taussig shunt will increase rate of the pulmonary valve preservation and also delay the occurrence of pulmonary insufficiency after the total repair in patients with Tetralogy of Fall. And I hope to see you all in this year for the ATCSA 2020. Thank you.
Any comments or any question from the floor? So, may I ask the question, please?
Oh, yes, thank you.
With the incision you perform the BT shunt through the sternotomy or the thoracotomy?
In every case, we did the thoracotomy because I don't like the sternotomy when you do the total repair. Yeah.
Thank you.
Thank you.
And the next speaker is Dr. Juthama from Sri Las Hospital. regarding long-term outcomes of right ventricle to pulmonary artery conduit placement in patient with congenital heart disease. Please, Dr. Chuthaman.
ขวาอย่างเดียวก็ได้ครับหรือว่าตรงนี้ก็ได้แล้วก็มี point laser ข้างบน
Thank you, Mr. Chairman. Good morning, everybody. กดไม่ไปฮะ Reconstruction of the right ventricular outflow tract using a right ventricle to pulmonary artery conduit has been a standard treatment in patients with congenital heart disease, in which there is either a discontinuity between the right ventricle and the pulmonary artery, or significant stenosis or insufficiency of the pulmonary valve. Although there are various kinds of conduit available, all of them have limitations, either durability or availability. Recent studies demonstrate that freedom from conduit reoperation at 10 years range from 40% to 96%. Only few studies produce satisfactory outcome at 20 years. At Sirat Hospital, RV2PA conduit placement had been performed since 1997, and the number of patients gradually increased each year. This study aims to assess long-term outcomes consisting of freedom from reoperation, conduit dysfunction, and catheter reintervention, patient survival, and factors that affect conduit durability. This is a retrospective study of 415 operations of RV2PA conduit placement from January 1997 to December 2018. The outcomes and survival are assessed by Kaplan-Meier analysis, and factors affecting conduit durability are assessed by Koch regression. This table shows demographic data. The median age and weight were 9 years and 23 kilograms. Numbers of male and female patients are quite equal. The mean conduit size was 20.5 millimeters. The median follow-up time was 5 years, with the minimum of 1 month and maximum of 21 years. The patients were divided into 3 groups: infants, children, and adolescents and adults. The size of conduits could be categorized into small, medium, and large. The majority of patients received large conduits. The major indications of patient placement were pulmonary stenosis and pulmonary atresia, which consist of 43% and 40%. The other 17% of patients include truncus arteriosus, loss procedure, and conduit dysfunction. The trend of conduits used has changed over time, as homographs were mostly used during 1990s and 2000s, while bovine jugular vein conduits have been more frequently used since 2011. The overall survival was 91% at 20 years. The overall freedom from reoperation was 84% and 56% at 10 years and 20 years respectively. The overall freedom from conduit dysfunction was 87% at 10 years and dropped to 35% at 20 years. The overall freedom from catheter reintervention was 77% at 20 years. When considering freedom from reoperation by subgroup analysis, the primary diagnosis of truncus arteriosus significantly had the worst outcome, especially after 5 years, while pulmonary atresia achieved the best outcome as high as 81% at 20 years. However, in the longer term, the outcome of pulmonary stenosis seemed to be more favorable. The age group also affects freedom from reoperation, as infants significantly had the worst outcome, especially after 5 years. At 10 years, while children and adolescents had similar freedom from reoperation of 87%, and children achieved the best outcome at 62% at 20 years. The large conduit size significantly produced the best outcome at 56% at 20 years. Types of conduits, however, did not influence the outcome, and freedom from reoperation was not significantly different. Patients having small or medium-sized conduits has a risk of reoperation approximately 7 times and 3 times higher compared to those having large size conduit. The infant truncated arteriosus and more than TSD C-score subgroups, although significantly has increased risk of reoperation in the univariate analysis and were not associated risk of reoperation in the multivariate analysis. In the conclusion of this study, our study demonstrated excellent long-term outcomes in terms of survival and acceptable freedom from reoperation and catheter reintervention, despite deterioration of conduit function. It was believed that patients should receive as large conduits as possible in order to extend life expectancy. Our study results appear fairly consistent with those from previous study. Thus, the larger the conduit, the better the durability. Although very kind of conduits are available, conduit longevity was not associated with types of conduit at all. This study reviewed satisfactory long-term outcomes and patient survival comparable to recent studies. Our study demonstrated better outcome in the large size conduit group. However, we also found that two large conduits, described as C-score more than TSD, carry 3 times higher risk of reoperation when compared with conduits smaller than 1 SD. Although this finding was only significant in the univariate analysis, it was an interesting piece of information as previous study discovered that conduit oversizing had worse outcome in children. Oversized conduit could be distorted or compressed by the sternum. Thus, conduit longevity would be reduced. The age of patients also affect the outcome. As the older age at placement, the better the conduit longevity. This may be explained by being older enabling patients to receive larger conduits. Some studies also demonstrate that the conduit type also affect conduit durability, but that could not be demonstrated in our study. Thank you for your attention.
Thank you, Dr. Chuthamat. Is there any question from the floor? Oh.
How do you follow up the patient?
I retrospective collect the data from OPD card.
You mean the patient has back to follow up to your center?
Yes.
Every year?
Some.
How
Maybe
many cases that you lost follow up?
15.
Because that's why you result you are really superb. Because you not count the loss follow up the patient.
Thank you.
Overall follow-up rate of our study is more than 95%, because we have good clinic and we follow up almost all cases in our center. And about the loss follow-up, it will can be correct by using Kaplan-Meier graph, so it will censor out. So our available data is reflect our really good outcome.
Because you saw that most of you use is homograph, right?
Yes.
And 20 years ago, I know that you prepare the homograph by yourselves. You cut the homograph and soak in the antibiotics and not use the cryopreserved homograph. That's why I question that, is how that can maintain to 10 years, 90%. It's different from the other center, because we know about the homograph that if you treat with the fresh homograph, it's not good. That's impossible. You cannot change the nature of the homograph. Because most of the result, the 20 years is meaning you use the old homograph in that group of the patient. That's why I question that you analyze it, 10 years you analyze that the reoperation or failure of the homograph is 90%. That, is especially in the small children that is impossible. If you can do that, you should not be change anything. You should be use the fresh homograph continually, right?
We didn't dig into the detail that at which time point we changed the protocol to use cryopreserved one. But I think most of the case is cryopreserved one because the volume of the earlier periods with homograph is very little. Most available later time.
The preparing of the homograph is not good with the fresh homograph. You soak in the oily antibiotics and keep in the refrigerator, allow for census, and you're waiting for the culture. After that, you put in the patient. It's not good. Why Ajahn Chilit Jenvichai try to induce the fresh cryopreserved homograph in our country.
Anyway, this is all real data, very real one.
Thank you, Dr. Thomas.
Thank you.
The next speaker is Dr. Prashya regarding comparison of right ventricular outflow tract reconstruction technique on mid-term to long-term pulmonary valve fate. Dr. Prashya, please.
Thank you, Mr. Chairman and Co-Chairman. Today we will be presenting with my title, Comparison of Area for Tract Reconstruction Techniques on the Mid to Long-Term Pulmonary Valve Fate. The repair of the tetralogy comprised of two procedures, included RVOT reconstruction and the VSD closure. And the reconstruction techniques vary with the PV morphology and size. The original one is the transannular patch or tap. First, to separate the valve with the RV ventriculotomy, and the patch it results in the free PR. But the free PR causes many adverse effects in long term, such as RV dysfunction, ventricular arrhythmia, and sudden death. So here's the picture of the tap, and there's the attempt to minimize the PR in addition to tap by adding the monocast into it. It helps in immediate to mid-term period, but at last eventually it also has the PR problem in long term. So the PV sparing techniques based on the widening of free PR by sparing the annulus has emerged, and the result is quite pleasingly reduce the PR, but is limited to the size and some diagnosis of patients, and may be the cause of the residual obstruction after all. So this study want to compare whether what techniques is better in long term regarding to moderate to severe PR among tap, monocast, and valve sparing technique. We enrolled 313 patients in retrospective patient. In all diagnosis underwent total correction by RVOT reconstruction techniques during the 10 years period. So RV2PA conduits were excluded, and many of patients with missing data such as lost follow-up, PV annular size, and C-score were excluded from the study. And we divided to the three groups. Statistical analysis as shown on the slide, and we use the propensity match score to eliminate the confounding factor between groups. the result is, let's start with baseline characteristics. The population is quite similar in each groups except diagnosis, PV annular size, and C-score. The severity such as Nakata index and alveolar pressure gradient are not significantly different. And let's take a look at the TAP group. It tends to have more anomaly and syndromes than others, but not significantly. Here is a table shows the preoperative data. The approaches are different according to different kind of techniques, and clamp time is shorter in PV sparing group significantly, and bypass time also, but just tend to shorter. These plots show you the intraoperative finding of valve morphology. The tricuspid pulmonary valve with the green light is highest in sparing group. Meanwhile, bicuspid valve is much more in the TAP group and monocast group. And it is significantly. And here's our post-operative data. There are shorter in ventilator time, ICU stay, and hospital stay in the sparing group significantly than any others. But please notice that the monocast group also yielded similar results to the sparing group. Let's move on to the echoes. Here's numbers shows the percentage of moderate to severe PR in each group, and valve sparing group has the lowest PR significantly, while in the residual PS they are comparable to the others, and no significantly in difference in pressure gradient, RV over LV ratio, and residual VSD. At the late follow-up, valve sparing group still has the lowest incidence of the PR significantly, but in contrast, TAP also has the lowest incidence of late PS, and monocast has a similar rate with the PV sparing in residual PS. The median follow-up time is approximately 7 years, and there is no significantly difference in mortality and reintervention. But please notice that the freedom from the moderate to severe PS and PR is longest in monocast group. And this table shows the effect of each technique on the late PS-PR matched by the propensity match score. You can see the red light show the high risk of the PR in TAP and monocast, both in univariable and multivariable analysis. And in the PS, surprisingly, there's a protective effect from the PS in TAP and monocast, but in just, especially in TAP, it is significantly protective, I think. And here is the graph shows the cumulative hazard function at the time that the PV sparing hazard ratio is 1. The TAP group has a risk of 2.5 times higher than TAP in the moderate to severe PR, and with monocast there is a 1.4 times higher. And now is the discussion. PV sparing technique may reduce moderate to severe PR in our study, and our data is quite similar to previous studies, such as Stewart and Sesson. The reason could be from the better morphology of the PV and the larger annulus. It might yield more success and easier to operate with. And the study also shows the shorter clamp time, ventilator time, ICU stay, hospital stay, consistent with the CESAL study in the past, and no different in post-operative PS, complications, and reintervention rate for each group. Both TAP and monocast are risk factor for late PR, but TAP inversely has the protective effect from PS. could be straightforwardly. And this study also shows the longest freedom from late PR and PS in monocast. And it's quite comparative to PV sparing in less ventilator time and ICU stay. And the limitations are the nature of a retrospective study, and a lot of cases had lost follow-up. In conclusion, sparing group PV sparing techniques can be a promising choice to reduce long-term PR, but still limited to some diagnosis and in good PV morphology. And monocast insertion can be an alternative with excellent results similar to the PV sparing compared with the TAP. Thank you.
Any comments or any question from the floor, please?
Thank you, Dr. Pachunya. I have one question for you. What kind of technique of the monocast do you prefer to use in this paper?
What kind of monocast technique? Which the PTFE cast.
Someone to do the press monocast on the floor, and someone press monocast at the roof of the hood of the transna pad. Yeah.
You mean that? I'm sorry about this question because I'm not sure in the operative report they didn't mention it.
Because the outcome of your monocast is very good, and I try to know about your technique.
Thank you.
Oh, thank you, sir. On roof, sir.
And may I ask about the material for monocast, please?
The material for the cast is a PTFE. Almost the case.
Thank you.
Thank you.
And the next speaker is Keisuke from Japan regarding adequate control of cardiopulmonary bypass by considering renal function evaluated by neutrophil gelatinase-associated lipocalin in pediatric heart surgery. Dr. Keisuke, please.
I am honored to have the opportunity to give this presentation. Thank you. Then no COI. There is no established strategy for perfusion condition of cardiopulmonary bypass in pediatric heart surgery. Adequate management of cardiopulmonary bypass that can prevent post-operative renal dysfunction lead to improved prognosis in post-operative patients. Post-operative renal dysfunction conventionally has been evaluated by serum creatinine and urine volume. Renal dysfunction assessment by serum creatinine and urine volume evaluate residual renal function. However, what we want to evaluate is renal injury caused by the use of cardiopulmonary bypass as much as possible without the influence of other post-operative factors. So we focused on the biomarker neutrophil gelatinase-associated lipocalin called NGAL. NGAL is after renal failure. NGAL is repeatedly expressed in renal epithelial cells, then excreted in urine. In this study, we used NGAL to examine the renal dysfunction after cardiopulmonary bypass in pediatric heart surgery. Furthermore, The results were used to optimize cardiopulmonary bypass management to prevent renal dysfunction in pediatric heart surgery. Subject included patients who underwent surgery for congenital heart disease from June 2018 to November 2019 using cardiopulmonary bypass who were under 15 years old. After we excluded those with missing data, we ended up with 124 patients. Urinary NGAL was corrected preoperatively immediately after admission to the ICU, as well as 1, 2, 4, 8, 12, 24, and 72 hours after admission to the ICU. Serum creatinine was corrected on the first and third days after surgery. We used KD-IGO diagnostic criteria to diagnose acute kidney injury. We collected data on cardiopulmonary bypass, including perfusion index, perfusion volume, DO2, head and abdomen RSO2, hemoglobin concentration, and intraoperative and postoperative lactate. Results. The correlation between AKI and NGAL levels was observed in the ROC curve. The area under the curve was 0.75. Cutoff value equals 7.8. We divided the subject into two groups. Group A is non-elevated NGAL group equal NGAL less than 7.8. Group B is elevated NGAL group equal NGAL more than 7.8. We compared the background elements, operative data, and cardiopulmonary bypass conditions of the two groups. There were 74 numbers in Group A and 50 in Group B. Their background data showed no significant difference in age, body weight, BSA, and rate of male. However, cyanotic heart disease was greater in Group B. Operative data showed longer operation, perfusion time, cardiac arrest time, and higher hemoglobin concentration in Group B. In monitoring data, there are no significant difference in perfusion index, DO2, and head RSO2 monitor. But we could see lower abdominal RSO2 as well as higher rate of decrease from pre to post-abdominal RSO2 and lactate value in Group B. Discussion. Although some reports say that there are more sensitive biomarkers for diagnosis of acute kidney injury, NGAL has the earliest reaction. This is why we used NGAL in this study. We anticipated that NGAL was elevated mainly due to intraoperative factor, not post-operative state. In adult cardiac surgery, the most recent recommendation is the use of goal-directed perfusion. For prevention of acute kidney injury, perfusion directed to DO2 index more than 2060 to 2072. In this study, there were no significant difference in perfusion index and DO2 between two groups. Abdominal RSO2 monitoring is a valid modality to obtain an easy, immediate, and non-invasive measurement of splanchnic RSO2 in infants. Abdominal RSO2 strongly correlated with serum lactate and systemic mixed venous saturation. In Group B, lower abdominal RSO2 monitoring value, longer operation perfusion, and cardiac arrest time, and a higher number of cyanotic cardiac anomalies were observed. In this study, DO2 or perfusion index was not significantly different between the two groups. Because the patient with cyanotic heart disease have collateral arteries which shunt from systemic to pulmonary circulation, we predicted renal perfusion might be insufficient during the surgery. we considered the need for another control strategy for congenital heart surgery, especially in cyanotic heart disease. There are some limitations to our study. Because this is a prospective observational study, we cannot recommend the novel perfusion strategy. Patient background were not controlled, so there may be other potential factors for renal injury. There's a need for more observation cases. In conclusion, the NGAL level at 1 hour after surgery correlated with the conventional AKI diagnosis by the KDIGO classification. In pediatric heart surgery with a cardiopulmonary bypass, it is possible to prevent post-operative renal dysfunction using the novel perfusion strategy which maintain abdominal RSO2 during the cardiopulmonary bypass. Thank you for your attention.
Is there any question from the floor? Dr. Keisuke, I have one question for you. Are you use the NGAL is routinely in the open heart surgery in Japan?
Down?
NGAL?
Adult? RSO2
Are you use the NGAL check routinely?
NGAL? No. This is for study use. So in my study, so NGAL is only pediatric cardiac surgery.
Study in pediatric?
Yeah, study.
And the adult cardiac surgery use the routinely NGAL?
No.
No.
I have one question. May I ask about how long we have to wait for the result of this biomarker?
What?
I mean, when you send to the lab, how long, how many minutes we have to wait for the result of this biomarker?
1, 2, 3. Most change in 1 hour. 1 or 2 hours.
So we have to wait around 1 hour from the lab.
Yeah. Yes. 1 hour after the surgery. It's very different. But 24 hours, not different.
Okay, thank you.
Okay, thank you, Dr. Keisuke.
Thank you.
The last topic, the efficacy of short-term prednisolone administration for pericardial effusion after cardiac surgery in pediatric patient by the Dr. Masahiro from Japan, please.
Thank you, Chairman. My talk is about efficacy of short-term prednisolone administrations for pericardial effusion after cardiac surgery in pediatric patients. I have no disclosure. Aspirin has been often used as treatment for pericardial effusion without cardiac tamponade after cardiac surgery. But aspirin was not always effective, so colchicine and steroids have been used in refractory cases. The object in this study to examine the efficacy of short-term oral prednisolone administrations for PE after pediatric cardiac surgery and the risk factors for drainage that was prednisolone non-responder. This study was retrospective cohort. PE was evaluated by serial echocardiography in diastole phase. Between October 2008 and March 2019, 1,275 cardiac surgeries were performed at our institution. PE required treatment after cardiac surgery complicated in 83 patients. 9 patients underwent pericardial drainage directly. 74 patients were given short-term prednisolone. Median age was 28 months. Body weight was 10.1 kilogram. 40 patients were made. This flowchart outlines our protocol for PE after pediatric cardiac surgery. For patients with signs of cardiac tamponade or circumferential PE more than 10 mm, pericardial drainage was directly performed. For patients with localized PE more than 5 mm or circumferential PE less than 10 mm, prednisolone was administered orally 2 mg per kilogram per day for 3 days. Patients with localized PE less than 5 mm were observed. Additional prednisolone was added as needed. These tables describe the patient's characteristics. VSD, TOF, and ASD were diagnosed the most. Short-term prednisolone was effective in 66 patients. Approximately 90% were responders. However, 8 patients were non-responder and underwent pericardial drainage after prednisolone. There were no deaths or complications with oral prednisolone administrations, nor did any patient have recurrent PE in this study. The median start of oral prednisolone administrations was post-operative day 8, and the median duration was 3 days. This slide shows the day of effect on PE decrease in responder group. Among the 66 responders, 50 patients had decreased PE within 3 days after prednisolone start, represented by the yellow bars in the figure. Here we show a typical early responder case. PE was decreased within 2 days. From here, risk analysis between the prednisolone responder and the non-responder groups were compared. There were no significant difference in patient characteristics. In preoperative factors, there were no significant difference. No significant difference was detected in operative factors. In post-operative factors, blood sampling and radiography echocardiogram were evaluated at 1 week after surgery. Cardiothoracic ratio tended to be higher in the drainage group, reflecting PE. Although not significantly different, CRP tended to be higher in the responder group. There were no infectious complications in this study. So it was thought that prednisolone contributed to the pericardial anti-inflammatory effect and reduced PE. Discussion. Few studies have focused on the efficacy of steroids for PE after pediatric cardiac surgery. The previous report suggests oral prednisolone for 7 days was effective in 90% of patients, whereas our regimen was oral prednisolone for 3 days and achieved a responder rate of 90%. Our short-term oral prednisolone treatment showed a shorter and a sufficient effect on reducing PE even compared to previous report. In conclusion, our short-term prednisolone administrations appears safe and novel treatment for PE after pediatric cardiac surgery. Further studies should be required. Thank you.
Do you have any comment from the floor?
I have two questions, please.
Yeah.
May I look at the slide of the outcome, the CRP level? Can you show me the slide? The CRP, the operative outcome that you show the CRP level.
What? Yeah.
CRP level.
CRP level, yeah.
Can you show me that slide, please?
Yeah. Not significant.
Not significant between both groups.
Not significantly, but steroid is anti-inflammatory effect. We thought prednisolone contributes the pericardial anti-inflammatory, and as like post-cardiopulmonary syndrome, and anti-inflammatory effect to contribute to the reduced PE.
Because it's quite non-specific
No,
biomarker. You conclude that?
still not the marker, but our further studies continued. We continued.
Okay. Thank you, Dr. Masahiro. Thank you.
Thank you.
Okay. The time to finish, and I would like to thank all participants and to close this session. Thank you very much.